Okay, I want to show you the infrapubic approach. Is a technique very well codified by Paul Perito. We make an incision between the pubic bone and the penis, and normally the technique has only 2 stitches for each corpora. I prefer to put 4 stitches on each corpora to close better as possible the corpora, because the bleeding after the procedure coming up from the corpora. It's very easy with this kind of approach, implanting the reservoir, because you can check very well how is the situation in order to prevent any risk of problems, artery injuries, or problem on the bladder. We make a little incision, only 1 centimeter, because I don't want to open too much the corpora, and we dilate only 1 time the corpora in order to prevent the risk to damage the vascularization of the penis, because at the end of the procedure the functional aesthetic result is very important. The functional result is the warm penis, the natural feeling of natural physiological erection, and the aesthetic result is the completely occultation of the tubes and the pump. We work in a little space, only 2 centimeters. In this video I'm using the Rigicon Inflaten prosthesis. Is a prosthesis that gives us a lot of satisfaction for the rigidity. I think the expansion and the rigidity of this kind of device is very, very good, and in my personal experience at the moment is better than the other 2 companies. We implant the pump between the testes, and we keep inside the drain normally for 4, sometimes 5 days. This is the result after 4 days. Every day we have almost 50 of serum inside the drain, but this is the most important thing. The patient after 4 days can touch without any pain, any discomfort, the pump, and after 7 days can start with the cycling to inflate and deflate the prosthesis in order to obtain a good elasticity of the penis. You can see the patient hasn't no pain, no hematoma, and he can touch without any pain the scrotum. The drain for 3, for sometimes 5 days, and the prosthesis inflate for 1 week to have an hemostatic work and to prevent the bleeding from the corpora. This is another patient, 53 years old, diabetic, with a dorsal curvature, with a Peyronie disease, very, very important. We perform always the infrapubic approach, putting 4 stitches on the corpora, and we perform the scratch technique. We break the plaque, we break with the scissor of Metzenbaum, and in the most difficult cases we can use even the knife inside the corpora to cut the fibrosis. It's very important to explain the patient that the penis will be just a little curve after the procedure. We make the modeling maneuver at the end of the procedure, and this is the final result. After 2 months, the prosthesis works inside the corpora and give the patient the perfect straight of the length of the penis. This is another patient with Peyronie disease after radical prostatectomy and several injection of alprostadil. We make even in this patient the scratch technique, and this is the result after 1 month. Another patient, complicated patient with colostomy, with severe curvature, dorsal curvature. This is the result after 2 months of the procedure. You can see the colostomy on the left, and the patient has solved completely the curvature of the penis and can manage without any problems the pump. In this patient, we implanted the cone seal reservoir in ectopic placement for the risk to having troubles, problems inside the abdominal wall. This is another patient with a severe curvature on the left side. He was very, very young, and after treatment with collagenase, with injection of PRP, nothing worked. This is the final result after 3 weeks after the surgical procedure with the penile implant. It's very important the time, because if you implant the prosthesis in 15 minutes, the risk to having an infection is very low. The two most common questions are in the patient with a big belly, in the fat patient. Look at this. This is a patient of 130 kilograms. If you put the patient brake on the table, you can do even in this patient the infrapubic approach. Obviously, you need a great experience. You can't start with this patient for the first time with the infrapubic, but this is the final result. The patient can activate, inflate and deflate the prosthesis. This is the final result after 1 year. And the aesthetic result is very, very satisfying for the patient. This is another one with a big belly. Is a patient of 150 kilograms with Peyronie disease. We perform, even in this patient, the scratch technique. You can see we break the fibrosis in the distal part of the penis. We check with the Brooks dilator the correct dilatation, and at the end we implant the prosthesis. Remain just a little curvature. This is the result after 5 days. The patient has the drain for 5 days. We remove after 5 days the drain, and this is the result, and the patient can touch without any discomfort the pump. It's possible with this approach having the ectopic placement. We put the finger and then the nasospeculum retractor inside the inguinal ring without perforating the transversalis fascia. We create a space with an agar, with a Brooks dilator between the muscles and the transversalis fascia, and we implant the flat reservoir. You can see now we are creating a new space because the anatomical space doesn't exist. We created a new space and we implant this kind of reservoir. It's a flat reservoir that works very well in case of previous surgery or in complicated patient after previous surgery like cystectomy or inguinal hernia repair. The other problem is the neurovascular bundle, but in the pinoscrotal you have the urethra. You avoid the urethra. If you have experience on penile surgery, you avoid from the neurovascular bundle. This is our video publication on Video Journal of Prosthetic Urology with my colleagues Federico Deò and Paolo Capogrosso. Okay, you can see we used the indocyanine before the procedure. You can see the green on the neurovascular bundle. The vascularization is completely green, and the Brooks inside the corpora. If you avoid this kind of vascular part, you can't have any problems on the glands, on some troubles on the neurovascular bundle. We perform even the revision of infrapubic approach with the infrapubic approach. We explant and reimplant the prosthesis. With this video, I'm responding to all the questions about your contra ege in your presentation. This is the result after 2 weeks, and obviously, without the pump for the new electrical one, or in the malleable, I think the best way to implant the prosthesis is the infrapubic approach. Why you have to open the scrotum if you haven't the pump? Obviously, is more complicated implanted the prosthesis from this part of the body, but at the end the rehabilitation is very fast. This is the patient after 1 month, and the discomfort with the pinoscrotal sometimes is this. The Maserati effect. Also, an expert implanter can have this kind of side effect, anesthetic effect. The tubes are coming up from the corpora, and the pump is very visible. We remove in this patient, after mechanical failure, the prosthesis with the infrapubic approach, and you can see we implant with the best aesthetic result the prosthesis. And this is the last frontier of the penile implant, the simultaneous implant, the prosthesis with the radical prostatectomy. The oncologist can work better because he doesn't need to stay careful of the nerves to prevent some problems of direction. We implant before the prosthesis and the pump, then we stop the procedure and we start with the radical robotic prostatectomy. We use this system, the name is Alexis. Is very useful to implant at the end of the procedure the reservoir. The 𝐏𝐃 and 𝐏𝐃 start with the radical prostatectomy, as usual.
As I know, there are some other Italian people do this at the same time the penile prosthesis after the radical prostatectomy at the same sitting. What do you think about that?
Just a moment, I finished the presentation. We are implanting the reservoir through the Alexis inside the abdomen of the patient. I put through the inguinal ring the Kelly to reach the tube of the reservoir. Federico 𝐷 passed me the reservoir with the robotic system, and we implant the reservoir exactly in the same position we use in the normal implant, in the ratio space. We grab the tube and then we connect the system. I think this is the new era in the treatment of prostate cancer, because the prevention, we are in the November month, the urologists offer the radical prostatectomy always at younger patient, and this is the best solution to prevent losing length of the penis and the discomfort after radical prostatectomy for the erectile dysfunction, and to procedure in one. You don't start infrapubic approach if you haven't a good experience on pinoscrotal, and don't start alone, because if you want to switch to infrapubic, you need an expert in front of you. But the most important question is how we bring the patient inside the operating room. Now there are many possibility on internet. I have developed many websites. One is penile implant channel, another one is a surgery tube with many testimonials, many interview, many surgical procedure, many video of penile implant. And it's very important explain before the procedure everything to the patient, how the prosthesis works and the length of the penis. This is the most important thing, because if you don't explain before the final length of the penis, then you can have a lot of problem with the patient. If the patient understood before the final length, you haven't any problem in the next future. And using another patient with the implant is the best way to give to the new patient the real sensation and the real way to solve the problem with the penile implant. Obviously, we say that the future will be the electronic device, but I think, and I repeat, a top-level implanter needs to be in his hand both the approach, pinoscrotal and infrapubic. Thanks a lot.
Thank you very much for this beautiful presentation, Gabriele. Are there any questions from the floor?
Very good job, thank you very much. I have some question. I have some more experience, especially the Peyronie disease. Sometimes before the operation you cannot understand how it's going in the corpus cavernosum. Sometimes it's so difficult, almost impossible to dilate, especially the distal crura, because of the Peyronie disease invade the corpus cavernosum. It's almost impossible to dilate. In that case, we have to cut the tunica inguinea and remove all this kind of fibrotic tissue. We call it the recalcitrant material, and then put the cylinder. Is there any kind of experience that you encountered this kind of so problematic?
Yes, I agree with you, but if you check very well the patient before with the hands, you can feel if the patient has a strong fibrosis. You can do an MRI scan before, and then you need experience. Obviously, if you are not very skilled in the field, you can have many problems to dilate the corpora. At the end of procedure, if is impossible dilate completely, you can leave one cylinder, but you bring at home the surgery normally. It's very difficult that you don't realize the surgery, even in the terrible fibrosis patient, in my experience. if you have a good experience, you can treat. If you haven't a good experience, you touch the penis, send the patient to another center, or bring with you the patient to an expert. I think is my point of view. Like me, I don't do radical prostatectomy. If I have a patient with a cancer, I bring to another colleague, because I'm focused only in one field of the urology. This is my point of view.
You mean that always before the operation, always it's going to be understand what's going on, but sometimes it's surprise. You don't understand.
Yes.
You change your.
Yes, but you are speaking a terrible fibrosis, about a terrible
Yes.
fibrosis.
Yes.
This is
And
not a surprise.
Do you change your technique and do change?
Yes.
Yeah,
For this reason, you
Yes.
can be an expert in pinoscrotal and infrapubic. If you have a problem with the infrapubic approach, because from the infrapubic part, the length from the corporotomy to the crura, to the distal part of the crura, is longer than in the penoscrotal. Normally is 11 centimeter. With the pinoscrotal approach, you stay more down, and normally the length is 6, 7, no more. And you can manage with the pinoscrotal better this kind of situation. But if you are able to switch from the infrapubic to the pinoscrotal, it's better, okay?
My last question.
Yeah.
What is your Italian penile length?
Mine or in general?
Longer than the length is the French people in the literature. And what you show us, everything is enormous size. And is it always, was it, or just a coincidence?
I don't know. I think 𝐏𝐃 know very well this kind of topic. You can answer to our friend.
Penis sizes are more or less the same around Europe, and
French is number one in the literature.
It's not a true information. The French sizes because of the
immigrants.
immigrants.
Dr. Saska, you were saying something?
I want to ask, thank you so much for your presentation, Professor. I want to ask, while this dilation, do you use normal hagars or
No.
Bernoton?
No, I don't use nothing, because in the vascular patient I prefer to preserve the vascular tissue, because at the end of the procedure, if the patient come back to my office and tell me, yes, the prosthesis is very good, works very well, but I feel the penis cold and no sensation, is not a good result, a functional result for me. If you destroyed too much the tissue, you can obtain this kind of side effect. Obviously, if the patient has a strong fibrosis, you have to cut, you have to break the fibrosis. But in the other cases, only with the dilatation, with the furlov, you can measure.
Which measure?
Only with the furlov.
Okay, furlong.
Only with the furlov. You can dilate and measure the length of the penis, and then you can implant.
For fibrosis?
For fibrosis, I can use even Rossello. Yes, everything. It depends on the fibrosis.
Yeah, sure.
Thank you for great presentation. I have two questions. The first one is, what do you think of the implants which expand in girth and length? What do you think about the rigidity? Do you like them? And the second question, do you think, is there any difference of angle of erection between the scrotal one and infrapubic? Theoretically, it has to be the same, but by the output levels of the cables, I feel that the angle of erection is kind of better, slightly better in the infrapubic approach. I just wonder your...
I think there aren't difference between the two approaches in terms of angle of the penis. I suggest always don't cut the suspensory ligament because the weight of the penis can put the prosthesis and the penis down, and the aesthetic result at the end, if the patient has a lot of fat in the pubic region, is not very good and satisfied, the aesthetic result. The other question?
About the cylinders that expand in your...
I don't like to use the 𝐿𝐃 or the other prosthesis with the expansion, because at the end nothing change. I have seen many patients after 10 years with mechanical failure and revision having an urn of 2 or 3 centimeters in the revision of the prosthesis without this kind of prosthesis. I think is only a commercial way for the patient.
So, do you face any type of complications with scratching technique for the patients with aortic?
Yes, one time I cut too much and I have an aneurysma of the cylinder, and after 3 months I have to repair this kind of problem because I cut the tunica, because the patient has a strong fibrosis, and in the operating room everything is good. At the end, after 1 week, the deformity of the prosthesis on the left side was anesthetic. I explained to the patient that can happen, and after 3 months I have repaired this kind of problem with a little graft in this part.
Thank you so much, Dr. Antonini, for this excellent presentation. I think we can proceed.
Thank you.
The next presenter.